Okay, I think everyone's here. Thanks everyone for taking time out of your evening to attend this webinar. I'm Dr. Wayne Chang and my partner, Dr. Gary Aghazarian. We're both general surgeons here on the West Shore, based out of Camp Hill. Just to let everyone know, this webinar is going to be recorded with a transcript, so it'll be distributed via email later, and for those who weren't able to attend. All right, so without further ado, I am going to start my presentation. One sec. Okay, so hopefully everyone can see my PowerPoint, but the topic of the night is hiatal hernias. So my portion is going to be going over what's a hiatal hernia, everything you wanted to know and more. And then here's a brief overview of the topics that we'll be talking about, a little background as to who I am, what are hiatal hernias, what are common symptoms that you'll experience with them, and then really we'll talk a little bit about, who are candidates for surgeries and how do we actually fix these. So quick introduction, I'm originally from Ellicott City, Maryland, so about 90 minutes south of here. I went to UMBC for undergraduate studies, and then the rest of my training you see listed there kind of all over the place. Virginia Tech down in Virginia, residency at University of Kentucky, and then I did an additional year of training on top of residency, which was at Anne Arundel Medical Center in Annapolis. So a lot of experience with minimally invasive hiatal hernia repairs, ventral hernia repairs, and the sort. So just to jump into it, what is a hiatal hernia? And I think this is very difficult sometimes for people to wrap your head around, because a hiatal hernia isn't like a true hernia where you can see a bulge or something popping out of your belly or in the groin area. It's completely invisible. You really shouldn't be able to see it from the outside. So just to break it down, you have your diaphragm, which is the muscle that separates your chest from your abdomen and helps you breathe. And then the esophagus is actually your tube that connects the mouth to the stomach. And so in this figure on the right-hand side here, you can see that your stomach normally sits in the abdominal cavity below the diaphragm. And then you have the esophagus connecting the mouth to the stomach. Now, whenever the stomach or even other organs get pushed up above the diaphragm, that's when it becomes defined as a hiatal hernia. And there's multiple different types that I'll show a photo later on, but essentially this is two separate types of hiatal hernias that are fairly common. So you can either have a sliding hiatal hernia, which is where the top portion of the stomach goes up above the diaphragm and then comes back down. It kind of goes up and down depending on your breathing or pressure that you're exerting on your abdomen. And then there's also what's called a paraesophageal hernia, and these are all subcategories of hiatal hernias, which is where a portion of the stomach actually protrudes up into the chest cavity above the diaphragm.
Sorry to interrupt, Dr. Chang, just real quick.
Yeah.
If anyone has any questions, feel free to put a question in the Q&A section, and we'll try to answer it as we go through today's presentation.
Yes, sorry, I forgot to mention that.
No problem.
So what are the symptoms? There are, unfortunately, a very kind of broad range of symptoms that you can get from hiatal hernias. A lot of the times these are fairly insidious. They happen to occur over many, many years, and a lot of people don't even realize they're developing a hiatal hernia unless it's been detected from some sort of imaging or endoscopy, or until it gets large enough where that actually starts to cause problems that brings them into the emergency room or to their PCP or GI doctor. But these are, all very common symptoms that get associated with hiatal hernias. So you can see that kind of runs the gamut from, chest pain, trouble swallowing, recurrent, respiratory infections, reflux. These can all be associated with hiatal hernias. So the other question becomes, how are they diagnosed? I alluded to it a little bit earlier, but imaging is a very common way of detecting these. So there's a thing called an upper GI study where people drink contrast, and that can highlight uh, a hiatal hernia. And in this case, you can see in the photo, you know, about 50% of that stomach is above the chest, or sorry, above the abdomen in the chest. Other ways of detecting it are on X-ray. That's a very common thing that someone might get a workup done in the emergency room and then just incidentally have a hiatal hernia seen. And then CT scans, also another very common imaging modality. And here you can see up top here is where you have a portion of the stomach pushing up into the chest right behind the heart. And then another very common way that these are diagnosed is a lot of people get endoscopy from above through the mouth with our GI doctors, whether for many different reasons, whether you're having a bleed or whether you're having reflux issues. And incidentally, or sometimes they're detected, they can be found through this modality. And you can see here, there's almost like a pocket that you're seeing above or in the upper portion of the stomach, and that is actually the hiatal hernia itself. So a common question that patients always ask is, why did my hernia, or how did I develop this hiatal hernia? How long has it been going on for? And actually, they're fairly common. So about 55 to 60% of people above 50 years old have a hiatal hernia, but only about 1 in 10 people have symptomatic hernias or hiatal hernias that do end up causing them problems. So common risk factors for people who do develop these usually tend to be on the older side, higher BMI. There is likely a genetic component in terms of having relatives who develop, who may also have it if you have another relative who is diagnosed with one. And then also issues such as like chronic constipation may be a risk factor for developing these hiatal hernias. So when it comes to actually managing them, there's a big question as to how do we address them. So really size and the symptoms are key in terms of managing hiatal hernias. So this is try to simplify the chart in terms of if you have a certain size of your hiatal, small, medium, or large, and whether you're having symptoms or no symptoms, when you should start considering, treatment versus no treatment. So in general, if it's small and it's not causing you any symptoms, it's very reasonable to just monitor it. Same if you have a medium-sized hiatal hernia. If you do become symptomatic, though, those are reasons to consider treatment. And then when you have a very large hiatal hernia, it's very important to have a discussion either with your primary care doctor or your GI doctor, whether you want to consider treatment or not. But anyone who is actually having symptoms related to the hiatal hernia should consider treatment. And then just in case people are wondering, what's small, what's medium, what's large, these are some generally accepted criteria in terms of small, medium, and large. And this is based off of endoscopy. So a lot of the times the GI doctors, they'll say this is a, small 2-centimeter hiatal hernia, or this was a large, 7-centimeter hiatal hernia. And then you can't really talk about hiatal hernias without talking about reflux. A lot of the times they go hand in hand, and especially in patients that have the more simple sliding hernias that I mentioned before, will have reflux. So up to 94% of those type of patients. In general, the first line of treatment for reflux is typically non-surgical therapies. So lifestyle changes, meaning avoiding acidic foods such as orange juice or tomato sauce that might aggravate your reflux, not eating after 6 p.m. or late at night because that tends to aggravate reflux as well. And then also things like reducing your caffeine and alcohol intake because both of those also trigger reflux episodes. And then when those don't really cut it, progressing to medication management, such as your proton pump inhibitors, like all your omeprazoles, pantoprazoles, or sometimes we also use H2 blockers, such as Pepcid, and antacids, such as Tums to treat reflux. But if patients start failing these medical treatments, or you start to have breakthrough symptoms, even though you've been on medication for a long time, or you don't want to be on a medication indefinitely, especially in our female population, there's been some concern of these anti-reflux medications contributing to osteoporosis long term, and they have really bad osteoporosis already. It might be worthwhile to consider a surgical consultation, at that time. So who is a candidate for surgeries? So essentially anyone that has any symptoms or complications, and these are all the ones that may pop up related to a hiatal hernia. So you can always develop these ulcers that can bleed and end up have someone end up in the emergency room for that. There's also a condition called Barrett's esophagus, which is where you actually start having changes in the lining of your esophagus, and that's considered a pre-malignant or pre-cancerous condition. And then other issues such as when the stomach becomes so enlarged, it can actually twist on itself inside the chest and essentially block off your ability to empty your stomach, and that's called a gastric outlet obstruction. So these are usually more emergent circumstances that end people up in the emergency room. But then other, causes would be someone who has recurrent issues with their reflux is so bad that they end up having multiple respiratory infections in any given year. And then, of course, if they've been on some sort of anti-reflux medication, but that's just not working anymore for them. And also another factor is BMI. So typically less than 40 is the cutoff for performing these hiatal hernia repairs, because in general, higher BMI has been associated with higher recurrence rates or failures of the repairs. And then these are a little, they may differ from surgeon to surgeon, but in general, the workup required to undergo a hiatal hernia repair include an EGD if it hasn't been done before, an upper GI study, and then there are two other studies that someone may obtain, such as a pH study, which is to evaluate how bad your reflux is, and then esophageal manometry, and that's to test how well your esophagus functions. So moving along, when we actually talk about repairing the hiatal hernia itself, once the patient has completely cleared the preoperative workup and everything appears to be related to the hiatal hernia, you can see on the right-hand side, this is actually a picture of how we fix these internally with small incisions. So this is the typical view that we see when we're after we've brought the stomach back down into the abdomen, and we're actually staring up into the chest through this photo. So there's usually two standard or gold standard approaches these days. So it's either robotic or laparoscopic repairs. And kind of like I mentioned, the goal is to bring the stomach back into the abdomen. And what we want to do is actually tighten the diaphragm around the esophagus. Now, we can't close it up completely because you need to have a channel available for your esophagus to have food pass through, but we want to tighten it up enough where the stomach itself can't pop back up into the chest. And so this is almost like a completed view of the repair once it's complete. You can see there's a couple sutures that have really narrowed down the hole or the gap that was in the diaphragm, and you can see the esophagus, comfortably down and back into the esophagus and the stomach back down into the abdomen. So if a patient has significant reflux symptoms, what they may get at the same time with the hiatal hernia repair is called a fundoplication. Now, There are lots of different varieties of it that are more into the details, but essentially what we do is we take a portion of the top of the stomach and we actually wrap it around the esophagus. So more commonly these days, people do what's called a toupee fundoplication here on the bottom right. And if you look at it, I always describe the patients that looks like a hot dog in a bun. And the whole purpose of it is to actually create a mechanical barrier or a mechanical valve to prevent reflux and stomach contents from refluxing back up into the stomach, or sorry, into the esophagus. And typically for these surgeries, it does require overnight stay in the hospital, but patients tend to go home the following day. And for restrictions, this would be a 4-week lifting restriction of anything above 15 pounds. And, there are certain eating behaviors that have to change as well during this postoperative period, at least for the recovery portion, which is eating. When you eat, try to remain upright as much as possible for about 20 minutes so that you don't lay flat. Because the problem being, when we're working up in this area, there tends to be swelling that occurs, and it can food can pass a little bit slower than you might expect. So if you're laying flat, you may accidentally regurgitate food back up into your mouth. So it's really important. One of the critical parts of the repair is actually not just the surgery, but also the recovery period. So I talked a little bit about, swelling that occurs around the upper portion of the stomach when we do these surgeries. So it's really important to adhere to these diet restrictions. And it's so one of the points is, any medications that you're typically on, they get switched to tablets that are crushable or capsules that you can open up and sprinkle onto whatever food you're eating at that given point. This is generally in place for about 4 weeks, and then it's also important to eat small, frequent meals during this postoperative diet because you can't really eat 3 big meals anymore in any given day. So you tend to go towards 5 to 6 small meals in a day. And then adhering to the postoperative diet plan. So I think I have a photo here. Yeah. So it's actually an 8-week diet plan, but the most important parts are week 1 and week 2. So week 1 tends to be only clear liquids. So that means, water, broth, juice, things like that. Also liquid supplementation like Ensure Clear. But after you've completed the first week of that clear liquid diet, you can progress, and you're doing well, you can progress to the week 2 diet. And this is more of a thickened consistency. So you can have cream of wheat, cream of whatever, and then smoothies, pureed vegetables, things like that. Once you make it through the first 2 weeks, the remainder of the diet plan is pretty unrestricted. There are certain things that you can see on the bottom line there that we try to avoid until you're done with the full 8 weeks, because these are things that tend to get stuck more easily or pass through the esophagus slowly. So you don't want to accidentally create a situation where you're eating like chips or raw vegetables and it gets stuck in your esophagus, because that could buy you a trip to the emergency room. So just to wrap things up a little bit, I know Dr. Aghazarian is going to cover some additional topics in his talks, but a couple common questions that patients ask. Number one, for people who end up getting that fundoplication for reflux purposes, a common question is, can I still vomit? And yes, short answer is yes, especially with the partial wrap. It can be more difficult to do so, but it definitely is still possible for people to vomit. And then another common question is a lot of people find that they end up passing gas more after surgery, having more flatus, and that is unfortunately common as well, because with these fundoplications where we're tightening up the stomach at that esophagus and stomach junction, you'll find yourself burping less, so that gas has to go somewhere. So it tends to go downstream and come out as flatus. And then, what happens if I eat too much? Most commonly, people will get that really uncomfortable feeling where they feel like food's stuck in your chest and they have to either stop eating, chase it with some water. But typically, that's an indication to the patient that they've probably either number one are not chewing properly or have eaten too much at any given moment and it's just is not passing through quickly enough. And then one of the final questions is, do I still have to take my acid reflux medication? And the answer for that is, it depends. For patients who don't have any history of Barrett's esophagus, the majority of the time after they have an anti-reflux operation is that they can come off of their acid reflux medication. But there are specific scenarios that may require you to continue taking that. So I would defer to your surgeon and your GI doctor in terms of whether you need to continue taking that or not. Okay. So this is our office number. This is my email in case you have some questions, but I will let Dr. Aghazarian start his presentation.
All right, thanks, Dr. Chang. All right, can you see that okay?
Mhm.
New slideshow. Alrighty. So I am Dr. Aghazarian. I am from Baltimore County in Maryland as well. Undergraduate wise, I went to Penn State medical school. I trained at PCOM in Philadelphia. Residency, I was at UPMC across the river here. And then I did a 1 year bariatric surgery / MIS fellowship down in Orlando Health, and then made my way back up to this area. So I do hiatal hernia repairs myself as well, but I wanted to talk about how obesity plays into this because I know Dr. Chang had mentioned in a couple of the slides how BMI can potentially affect having a hiatal hernia. So as he mentioned in one of his slides that a risk factor for developing a hiatal hernia is in fact your BMI. And studies have shown that excess body weight is a independent risk factor for developing a hiatal hernia and potentially esophagitis or inflammation of the bottom part of the esophagus. So first, before we talk about the treatment options for this, we have to talk about what obesity is and how it's defined in today's medical world. So the national and international medical and scientific societies recognize obesity as a chronic progressive disease that is due to multiple factors. And the second bullet point there, the prevalence of obesity has increased over the years. So it's a disease process that is worsening. And then how do you calculate or how do we define obesity? The biggest marker that we use is the BMI, which is basically your weight over your height, and then it's calculated in kilograms over meters squared. And then so in the lower section here, BMI, there's different categories, but overweight starts at a BMI of 25 to 30, and then obese is 30 to 35, and then morbid obesity starts at greater than 35. So what is the treatment of obesity? So there are several approaches, and it's a multifaceted approach, meaning you need multiple areas to have successful weight loss. And these include lifestyle intervention, anti-obesity medications, which I'm sure everyone's seen those on TV, the Wegovy, Jardiance, Ozempic, those have become very popular. And then also weight loss or bariatric surgery. So how do you qualify for bariatric or weight loss surgery? So it's based, a lot of it's based on insurance policies, but you need to have a BMI of greater than 40 or a BMI of greater than 35 with at least one or two obesity-related comorbidities, such as diabetes, high blood pressure, high cholesterol, and then inability to achieve weight loss through other methods. So hiatal hernias, unfortunately, they're not part of the insurance approval for getting weight loss surgery. And then why is obesity bad and something that should be looked at is because it's a second leading cause of premature deaths. And undergoing surgery can resolve many of the associated conditions related to obesity, such as diabetes, high blood pressure, high cholesterol, and reflux. So, the first procedure I want to talk about is the gastric bypass. It's the most or it's the oldest operation still around for weight loss, and so these operations can be performed with a hiatal hernia repair as well. And as Dr. Chang mentioned in his slides, where we close the muscle layer, that would be done with this operation for weight loss. The other part with the wrap that Dr. Chang was talking about would not be performed because that would be now the weight loss operation will be taking that part. But with the bypass, we create a small pouch up top, and then it bypasses the old stomach, and then so food will go down through the small intestine and meet at a later point where digestion will start. So the bypass is a great procedure for people who have severe reflux, whether or not it's due to a hiatal hernia. And if people have a hiatal hernia, this is a great procedure if their prior workup has shown that they have esophagitis or Barrett's esophagus or things along those lines, because this will completely eliminate or should completely eliminate reflux. And then now the most common operation that we perform for weight loss surgery is the sleeve gastrectomy. This can be performed with a hiatal hernia repair, again, closing the muscle up top at the diaphragm, and then removing the outer portion of the stomach will complete the sleeve gastrectomy. Now, this operation is the most common because it has the least amount of side effects and complications compared to the gastric bypass per se. However, with the sleeve gastrectomy, there is a chance that reflux could worsen. So it is something that you would need a proper workup before surgery, before committing to the sleeve gastrectomy with a hiatal hernia repair, because there is a chance that your reflux could get worse. So if you had prior esophagitis or inflammation of the bottom portion of the esophagus, or you had Barrett's esophagus, this would not be a good operation for you due to the risk of reflux developing after this operation. And then here's just some of our office information. Stop sharing here.
So if anyone has any questions, I think at the top of your Teams screen should have a Q&A button, and you should be able to send us any questions that you have, and we can always answer them either on the chat or in the Q&A if possible. Oh, someone has their hand up.
We don't allow
Hey,
microphones for the attendees.
Gotcha. Okay. Is there any way for you to write a message in that Q&A? If you send it, we will see it.
Mm-hmm.
Doesn't look like it. I don't think there's any way we can turn on the chat, can we?
No, we can't.
Okay. All right, well, we're waiting for Mary. Oh, okay. Let's see. Oh, looks like someone, yes, asked a question. Hey Laura, are you able to see the question that was just asked?
Yes. Would you like me to read it?
Um, yes, as long as it's okay,
Yep.
without like personal information.
Yep. If I have a small sliding hiatal hernia, is there a way that I can get my stomach to slide back into the abdomen?
Good question. So there's nothing that you can do yourself. Uh, Unfortunately, with the sliding hiatal hernias, um, it basically goes up and down depending on, whether you're exerting yourself. Like, so anytime you're straining or coughing or doing a sit up or basically activating your core muscles, that would cause pressure develop on the or to develop on the inside of your abdomen and push your stomach up. So unless either there's a repair or you're able to tether or anchor the stomach in the abdomen surgically, there isn't a way, holistically or naturally, to be able to prevent it from going up.
Yeah, I think you can, going what Dr. Chang said, if you try to avoid something that's causing this, such as like constipation or coughing, if you can control those symptoms, then there may be a chance you could prevent it from going up as much. But like Dr. Chang said, there's nothing really naturally you can do.
Yeah. And I guess one thing I'll, while we're seeing if other people have questions, one thing that I think people don't appreciate because these symptoms or the way these develop is uh, over such a long period of time is that, a lot of the times I'll ask patients, have you been having difficulty swallowing, meaning food gets stuck in your chest or it doesn't go back down? Have you had episodes where you're regurgitating food, meaning like you bend over and food comes out undigested? Or do you have issues in terms of eating, like you feel like the amount that you're able to eat, or you get full more quicker? Those are all pretty common symptoms that people have with hiatal hernias, but then there's also the reflux component to it. So it's not just, hey, I have heartburn, but people who have really bad reflux, they can't lay flat when they sleep. They have to be propped up with a couple pillows, or they have the fancy beds that you can elevate your head. Um, they usually tend to have breakthrough symptoms in the night where they'll wake up in the middle of the night, almost like choking from acid or that kind of acidic sensation in the back of your throat. And that can be, really bad because if you're aspirating or if you're, um, inhaling any of that acid into your lungs, that can cause the recurrent upper respiratory infections. What else? Any other questions? All right. Shall we cut it off, Lori?
Sure.
Okay. Well, if anyone has any questions, you know, here's our information. You
Mhm.
can reach out, or honestly, if you just want to have a discussion with your PCP or GI doctor, like I said, those are usually the most common um, providers who initially diagnose these because your GI doctor will see it either from your endoscopy or your PCP if they're reviewing, your recent visit to the emergency room, and they notice a finding in your discharge paperwork or your imaging, that might be a way of catching a hiatal hernia. Oh, is there a new post?
There's another question. Is
Okay.
strenuous work, shoveling or raking ill-advised?
Mm.
Good question. So I think no, the short answer is no. Because you do a lot of things on a day-to-day basis that are probably worse than strenuous exercise, like coughing, sneezing, straining while you're going to the bathroom. So all of those probably exert more force on your abdomen than lifting or doing strenuous work. But I think the most important part though is if you're actually symptomatic, like if you are having problems from a hiatal hernia, um, it might be important to get that evaluated first, as opposed to like necessarily like limiting your day-to-day activities. Oh, is there another question? I know it looks like someone else is raising their hand. So, if you're able to, type any questions in the Q&A, I'll just remind at the top there. That's the quickest way for us to see your question because our chat and video and microphones are disabled for guests.
Yeah, I think that may be it. We'll be sending this information out, correct, Dr. Chang?
Yeah. Yeah, all this information will be, this was recorded. We have our transcript, so that'll be shared with all the attendees or people who signed up.
Okay.
Sound good? Anything else come through, Lori, or is that it?
That is it.
Okay. All right. Once again, thanks everyone for joining us tonight. And yeah, if there's any questions, feel free to reach out.
Yep. Have a great night.